Hi everyone, I'm Peter Spilsbury from the Strategy Unit. Sorry for the delay in getting you in. We had a freak thing with Zoom where it kept kicking us out every time we tried to start, so very sorry for that. I hope we haven't inconvenienced you. Welcome to the fourth event as part of the Insight 2020 Festival. Early on in the pandemic, the health think tanks and ourselves, the Strategy Unit, were asked to form an analytical collaboration to try to support the effort in responding to COVID. And we had three roles. We were asked to try and address some short-run questions from the centre, especially in the early days when everything was so uncertain. We were asked to do a lot of work around collating and updating the emerging evidence base against a set of questions that were seen to be important in terms of the national response and thinking about recovery, and that turned into a mammoth task actually. And then also we identified a range of important questions, particularly looking at the implications of COVID and what that might mean for recovery, and have started a programme of addressing those. Some of those are completed, some of them are still underway. And the full set of questions and the outputs from the work and those evidence updates are all collated on the Strategy Unit website under the COVID-19 tab. So if you aren't familiar with that as a resource, then please use it because there's a huge amount of material on there. Today, we're going to reflect on a few of those pieces of work with three of the key participants in the collaboration. The fourth, Siva Anandachiva from the King's Fund, Chief Analyst at the King's Fund. We need to congratulate Siva and his family because Siva's on paternity leave at the moment, so he's unable to join us today. But we do have with us, which is fantastic, Sarah Scobie, Deputy Director of Research at the Nuffield Trust. Hi, Sarah. Charles Tallack, Assistant Director of the Real Centre, the new Real Centre at the Health Foundation. And just a plug, the Real Centre's producing its launch report. I think the event to launch, that's the middle of this month, and I'm sure Charles will take the chance to just mention the date to you all because there's some fantastic insights in that piece of work. And then we've got Stephen Wyatt, who's a principal at the Strategy Unit, and also for those of you who are in the Midlands and interested in the Decision Support Unit network, Stephen is the Chief Analyst for the Midlands Decision Support Centre that's supporting that network. And then as facilitators, we've got Alison Turner and David Callahan from the Strategy Unit. And Alison led the entire evidence synthesis component of the collaborative's work. Which, as I say, was a kind of turned into an extremely tall order because of the enormous amount of research information that's been coming out during COVID. And again, for those in the Midlands, just a chance to meet Alison, because Alison's heading up the whole sort of knowledge library part of the Decision Support Centre for the Midlands. So earlier this week, I don't know if many of you had a chance to attend some of the earlier sessions. We've had 3 sessions so far. The first one was looking at how we might strengthen NHS and social care analysis going forward, featuring quite a tour de force performance actually from Ben Goldacre, for those of you who saw it. We then had, I think, a really fascinating and actually quite moving session about what COVID has meant for social care, with some really important insights from a colleague who was a user, someone of lived experience, explaining what COVID had meant for him. And then we had a third session yesterday with our partners Ipsos Mori, talking about how we can perhaps get a bit more systematic in how we understand the way the public and patients and service users and indeed clinicians and care providers, how people are weighing up, making judgments about how to trade off risks and how that's changed in the time of COVID, and what that might mean for how we have to think about recovery. So all of those 3 sessions, I think, highly relevant background for today's discussion, and all of them are recorded. So if anyone wants to see those, go back and see them. They're all going to be there on the Midlands Decision Support Centre website. So anyway, the way we're going to work today, each panel member is going to do a 10-minute thereabouts slot on a piece of work that they've been undertaking, and some of the questions and insights that arise from that. And we'd really encourage you all to post questions as they go, because we'll have a Q&A at the end of that session, and we'd like to draw on your questions. And because this is one of those great occasions where you've got the people on the panel who actually do the work, I can say with great certainty that they like nothing more than really difficult technical questions. So so the more of those you can ask, the happier they'll be, I'm sure. And then we'll have a discussion amongst the panel members about their work, and about particularly thinking about what are the things we don't know, and how we might address that going forward, what are the critical things. And again, please use the chat function to put your questions in, and Alison and David will be collating those for those points. And we will finish on the dot at 11:30, I promise you that. And just as we start, because this whole festival is a completely new venture for us, we think it's an important thing to do. We're getting a lot out of it ourselves, and we hope we're getting a lot for participants. But it really helps us to know who's on the sessions. So if I could ask you to post in the chat now who you are, what you do, and where you do it. So if you could just do that for us, and I'll just pause for a few seconds while you do that, and then at that point I'll be introducing Charles. And just while you're typing your details, if you could just note the housekeeping thing. So if you could keep your microphone muted during the session. Please note the session is going to be recorded, and we'll make the link available to you all. And yeah, please take the opportunity to say hello and introduce yourselves. And anything you can do to share the fact that this festival is on. It's got another 5 weeks to go. There's some fantastic sessions lined up. Please do that, and try and encourage your friends and colleagues to take part. Great, I can see they're all flowing through. Yesterday we discovered we had a global audience, so that was quite exciting. We had people from Croatia, Barcelona, and all sorts of places. So let's hope we've got an international flavour today too. Charles, are you ready to go?
I'm ready. I'm somewhat transfixed by all the names appearing on the screen. I've spotted quite a few people I know, which is a very nice surprise to see they're here. Yeah, anyway, I'll shut my chat down now so I don't get distracted by all that, because it's all very interesting. So I'm just going to talk a bit about some of the work that we've been doing in the Health Foundation, but also drawing upon work done by others on the impact of the pandemic on health. And in a way, that kind of, is one of the central questions, and I guess it's one of the early questions that people were very interested in. I should just say, so I am from the Health Foundation's Real Centre. So the Real Centre is launching on the 16th of October. I sent around at the top of the chat details of our launch event, which is going to be, we have got a lecture by Sir Andrew Dilnott, who is chair of our oversight board, with a really good set of speakers. And we're going to basically be looking at well, the importance of taking a kind of long-term view of things for decisions which are made today, thinking about how they'll play out tomorrow and in the future, but with a look back over what's been happening over the last 20 years. So we've been working with Stephen Wyatt at the Strategy Unit, and Peter and colleagues there on doing a really good in-depth analysis of what's been going on in the last 20 years, which actually I think surprised all of us. Even though we like to think we know about what's been going on, I think the change over the last 20 years have been absolutely fascinating and almost certainly surprising to people. So please sign up for that. Anyway, that's the plug. Thank you for inviting me to do that plug, Peter. So Alison, can you just move to the next slide? So thinking about the impacts of the pandemic on health, what I'm focusing on here really is the negative impacts. There are clearly some positive impact. So there's almost certainly been a reduction in some forms of injury. We know that from people turning up at A&E, fewer people turning up for injury. There's been a reductions in things like some infectious diseases, because some of the social distancing measures have also caused falls in that. There are things like road traffic accidents. There are almost certainly be reductions in those. But I think what the net impact is clearly a negative one. And actually what I wanted to talk about here was just the types of negative impacts there are. So I think this is a sort of quadrant which has got, I think there are two main, we can think about the impacts in two ways. One is about years of life. So people who've had their lives cut short as a result of COVID or some other impact. And then there's, of course, the quality of life. So thinking about those two dimensions, but for people who contract COVID-19 and people who don't contract it. So just in terms of quality of life, there's, for people who contract COVID-19, as well as obviously the period of illness, which can be quite profound, there are, you know, the kind of what's emerging about long COVID. People who don't contract it, there's effects on quality of life from their reduced healthcare use. So maybe they're delaying treatment for things which would improve their quality of life, or maybe they're just not getting treatment at all. And of course, there's all the wider effects from which we read about all the time, the kind of isolation, uncertainty that people face, which, you know, uncertainty perhaps over their future prospects, their future employment, which causes anxiety, and we know that's linked to negative health effects, as well as being a kind of anxiety in itself, a kind of negative impact. And then obviously the impacts of unemployment, and yet I think we obviously expect to see this coming. We've probably seen, not obviously, that's still emerging, the impacts on employment. And then there are the impacts on years of life. So clearly, you know, one which is in lights is people dying from COVID-19. But we don't know how many life years they lose. People who contract COVID-19 and then recover might also have a shortened life. Again, we don't know some of these things yet. And then people who don't contract COVID-19, there are impacts on years of life, again, from reduced healthcare use. So people not getting diagnoses of cancer, for example, as soon as they might have shortened people's lives. And of course, as a result of some of the mental health issues, there could well be increases in suicide. So that's the kind of the totality of the kind of impact. So let me just talk now about what we know about some of those. So Alison, if you could just move to the next slide, please. So looking at the top right quadrant, what do we know about the impact of people who get COVID-19 on years of life? So we know that, and this is the figure that is pretty much the BBC quotes every day now, is that they're in England, these figures for, is maybe where they're not quite the same as the BBC figures, 37,367 people died with COVID within 28 days of a positive test. However, what we also know, so this was at the 28th of September, what we also know is that 50,066 people died with coronavirus mentioned on the death certificate, and that is from the ONS official data. These are quite different numbers, and I think it's quite interesting that the figure now being put to us every day is actually the top figure. Your people may remember the controversy about whether it's 28 days, the cut-off. You know, I think originally Public Health England were counting a longer cut-off period, but we've now settled on this 28 days. But there's one other figure which is relating to the whole of the years of life lost. So Alison, if you can just move on to the next one. So I've extended this little box down to people who don't contract COVID-19, and that is 56,000, and that's what people call excess deaths. So they're basically the number of deaths there have been since the start of the pandemic period. 20th of March, it was the week I think we saw the first significant number of deaths. I think there are 100 deaths in that week. 56,611 more deaths of people than in the previous 5-year average. And I think one of the things that I think most people now, statisticians, analysts, think is that this figure is probably the best one to use for the total impact of the pandemic. even within the ONS figures, the 50,000 and 66, that's people who've had COVID mentioned on their death certificates. I think there are some reasons to believe that there were some cases of COVID not counted there. So there's a question about, of those 56,000, how many of those were actually in the top box, dying from COVID-19, and how many were in the bottom box? So Alison, if you can just move on quickly. And so there's quite a lot we don't know about the impact on years of life. So of the non-COVID excess deaths, so the difference between the 50,000 and the 56,000, what is the causes of those? Like, is that because they're not getting healthcare use? How many of those are suicides? What other things are they? We don't know that. And then a very critical question is, we talk all about deaths and excess deaths, but how many years of life have been lost? Like, deaths is a very crude measure. And, clearly there, in some cases, people's lives might have not been shortened by very much at all. In other cases, they might have been shortened a great deal. So someone who dies in their 60s probably would have expected to have lived for quite a long time. And I think some of the work that actuaries have done have said that, often we talk about people, they had pre-existing conditions. Actually, for people with pre-existing conditions, even in their 70s, they probably could expect to live for another 5 years. But we don't know how many years of life have been lost. So Alison, if you can just move to the next one, please. So looking now at quality of life, people who contract COVID-19, we now know that there is this thing called long COVID. So there was a paper in Nature about that a couple of weeks ago, but we still don't know much about that, clearly, because by definition, people haven't had COVID or had the after effects for very long. We don't know how long that's going on for. We don't actually really know much about the prevalence of that. And then, Alison, just could you move on to the next one? And then for people who haven't contracted COVID-19, what about the impacts on quality of life? So the first thing I wanted to talk about was, we know that people have not been using healthcare in the way they were before the pandemic. So this chart shows analysis that we did as part of the analytical collaboration. We did analysis of primary care data, CPRD, which is a person level primary care data set covering I think it's around 5 to 10% of, or probably about 5 to 7% of general GP surgeries. And this looks at, we can look at a number of different measures. I've shown you one here, but this is the referrals to secondary care. And the line there is the lockdown week. So this is changes from the base. So that's the base we've taken is the average of weeks 2016 to 19. And as you can see, there was a very, very sharp drop in referrals and tests. So it was about 75% in the week after lockdown. Referrals have recovered back, although we're still 40% down, and people being referred to for tests is still down by about 60%. Or this is not the most up-to-date data. This is week 25 of the year, which was probably around the middle of the year, so beginning of July. So if you can move on to the next slide, Alison. And this is also from the same analysis. And this is, I think this is a really, really interesting one. This is looking at consultation rates, so GP consultations, again, compared to a base for people with different long-term conditions. So first thing to notice is there was a big spike in the lockdown week. So I think what we think is that this is either patient-initiated consultations with their GPs or GPs bringing people in who they thought were going to be at risk. So you can see this is all in our, there's a publication on our website. You can look at this. You can actually play around with this. This is an interactive chart. You can select bits. It's quite noisy with lots of these data lines, but you can pull out particular ones. So COPD, people with COPD, consultations in the week before lockdown were about 160% up on what they would normally be. And then as you can see, after lockdown, they reduced a lot. Cancer now is, or week 25 was not, had actually recovered most. But as you can see, the pattern of recovery was quite different. And the bottom line, the green line, is none of those non-communicable diseases. And as you can see, they fell by more. So people who didn't have those communicable diseases, consultation rates fell by more. And I guess that's encouraging. At least people with long-term conditions were still consulting, and a bit higher rate than people without those things, but there's been quite a significant drop off. And then, Alison, if you could just move to the next one. And then what about all the impacts which aren't to do with people seeking healthcare? What about the impacts on isolation, uncertainty, unemployment? The ONS has been collecting some really, really interesting data on this, which they published a couple of weeks ago. I think it was called like Diary of in Pandemic or something like that, which looks at they've got obviously their standard measures, which they've got routinely now as part of their wellbeing survey on anxiety and happiness. And then this is, so the purple lines there are the pre-COVID levels, and you can see what's happened to anxiety. So that's the first chart. So it was much, much higher early on. The level is still higher than it was, but it's fallen. And then well-being, happiness, again took a bit of a hit, so it fell by about 1 point in April, and now it's kind of recovered, which is pretty amazing, and probably says something about the way that, I don't know, we adapt, and the way that we score our happiness probably has a tendency to just, we may well have a level that we just kind of will revert back to. But this clearly has the anxiety ones, and there are other things they're measuring as well, has clearly an implication for people's, well, this is a measure of health in itself, of well-being, but it will have also implications for other things as well. So just moving on, and then what we don't know about the impact on quality of life. So we don't know, we know there is a thing called long COVID. We don't know the prevalence of that, and we don't know the lifetime impacts. We know quite a lot now about healthcare use and how that has changed over the pandemic. What we don't know is what that means. Like, how bad is that for people? In some cases, it may well be people not going to A&E for things which they didn't really need to go for anyway. But in other cases, it might be people not going when they've got suspected cancer, which would obviously have a far bigger impact. We don't really know. We can describe the activity, but we can't really describe the impacts. And then clearly we don't know what the longer term impacts of lockdown and consequences are. So, there are going to be some pretty profound economic impacts and societal impacts. They will have consequences, but we've got no idea. They may well turn out to be bigger than the direct impacts from COVID. And I think that's it for me. I think, Alison, can you just see? Did I have another slide?
Yeah, no, that's
the end. So it's quite hard not being in control of the slides, because I'm not quite sure which one I'm at. But yes, I hope that's I think it's probably roughly within time.
Yeah, we started a bit late, but that's brilliant. Thank you, Charles. So please, reminding people, put your questions for Charles in the chat, and we'll kick straight off now with Sarah. Sarah, are you doing your own slides? Is that?
Yeah, if that's okay.
Yeah.
Great. So hopefully everybody can see those.
Yeah.
Yeah. Good. Okay. Well, thanks very much, Charles. I'm going to sort of actually pick up on a few of the themes that you've drawn on in terms of how the pandemic has changed how we use health services, and what the implications of that might be. Particularly, I'm going to talk about place of death. So this is a chart of excess deaths in different places of death. So these are deaths registered by week from the middle of March up to the beginning of September. And as Charles mentioned, this excess death measure compares the number of registrations with the average for the previous 5 years for that week. And so with the chart, you'll see there's this very dramatic peak in April and early May, with the hospital deaths peaking earlier than the care home deaths. So the care home deaths are in grey, But what I'm particularly actually going to focus on is deaths registered for people dying at home. So these did also increase with a peak towards the end of April. So that's registrations towards the end of April will be people who died a couple of weeks earlier, probably, particularly at home, because there's a longer time lag in those deaths being registered. And I think there's a few things to note there. One of them is that actually very few of those deaths, only around 2 to 3%, were registered as being related to COVID. And so some of those excess deaths may be some of the COVID related deaths that weren't recognised or not. We just don't know. But the thing I actually want to focus on is more is sort of what's happened afterwards, really, and what we've seen for the last 3 months, and this chart from a couple of weeks ago, but the same pattern has continued, is an above average number of registrations at home, running at about an average of about 750 or so a week, and that's continued throughout the period. And I think there's some really interesting questions here about why this is, and sort of what it means. So one of the things to note is that it's quite likely that there's a sort of displacement effect from deaths that might have been happening elsewhere. By the way, ignore some of these funny blips here, which is to do with differences in when the bank holidays occurred in each year. It's quite likely there's been a displacement of hospital deaths. And some of this could be positive choice. So when we put this chart out, I had quite a bit of Twitter exchange with people about this issue. And you know, we know that hospital visiting has been severely curtailed. So for people at the end of life, the prospect of being kept apart from their families, or for families not wanting people to be admitted, is obviously really massive. So it could be there's an element of patient and family choice. It could also be there's an element of people being deterred from seeking help. So this is the figure on the right, a chart from some of the Health Foundation and Ipsos Murray work on how comfortable people feel attending hospitals, and so that in May in particular, only just over half of people would have felt comfortable seeking treatment. That has improved. So probably there is a mixture of things going on here. There's some positive choice about where people are seeking care at the end of life, and there's also people just not wanting to go to hospital, and that might of course be affecting their outcome if they're not seeking help early enough. So that might be a contribution to the excess deaths. We don't really know for sure. It could also be that there's a displacement of care home deaths. So in the world of patchy data, I think social care and care home data ranks very high on the patchiness of data. We don't actually really know about the occupancy of care homes at the moment. It's rumoured, you know, there's some anecdotal evidence that it's only about 75% occupancy, and that's because people are struggling to, you know, are not wanting to be admitted to care homes. Families aren't wanting to admit them, again for the same reasons around not being able to visit, perhaps uncertainty about the risks around COVID, given the huge numbers of deaths in care homes. But of course, the other side of this is that if there really is only 75% occupancy in care homes, then mortality in care homes is actually well above the 5-year average, but we don't know the denominator. So that's another question. So I think either way, I think there's a huge set of implications here. So first of all, you know, what's the impact on quality of care that patients and families are getting? Are they seeking help when they need it? You know, do they have the right support at home? and some of those long-term impacts that that Charles mentioned, we just don't know. And I think there's also then huge implications for services as well. So for a long period of time, there's been an emphasis on providing better end-of-life care at home and in the community, reducing numbers of deaths in hospital. We've now seen a massive shift in that. About 30% more people are dying at home than prior to the pandemic. Is that going to be a long-term trend that needs supporting in terms of end-of-life care? And what is it going to mean as well for demand for hospital care, given how many admissions are for people at the end of their life, and treatment and interventions at the end of their life. So I think, yes, in terms of something that's going to have long-term implications, I think this for me is definitely something to be keeping an eye on and requiring further analysis. So I think I'll finish there.
Thank you very much, Sarah. So you're going to unshare your screen, I think, and then we turn to Stephen. If that's correct.
Yep, I've unshared.
Yeah. Great. So Stephen, over to you.
Thanks, Peter. I wonder if I could ask you to cast your mind back to the winter earlier this year, before COVID, and to think about aspects of the health and care system that were giving us cause for concern at that time. So there were several, there always are, but one of the long-standing issues was the state of our major A&E departments. So pressure on these units had been building over the last decade or so. Attendance rates had grown steadily, although comparatively slowly, but breaches of the 4-hour target had rocketed. Immediately before COVID, about 1 in 4 patients attending ED spent more than 4 hours in the department, about 5 times the rate we were seeing 10 years earlier. There had been quite a long and bitter debate about how to measure ED performance, and it had become the norm in lots of EDs to have 5 or 10 or more patients waiting on trolleys in corridors for a hospital bed to become available. And the service, it seemed to me, was a bit of an impasse. Everyone was agreed that we couldn't carry on as we were, that it was bad for patients and bad for staff to operate in these ways, but there were few practical or radical solutions that were being proposed. And then on top of that, COVID happened. So Alison, could you move on to the next chart for me, please? So this chart shows what happened to ED attendances in response to the COVID shock. So the yellow line shows the number of attendances each week in major EDs in 2019, moving from January in week 1 through to mid-August at week 32. And the blue line shows the same counts of attendances, but in 2020 over the same weeks. So just a few sort of points of reference. So the first cases of COVID were confirmed around about the end of January. That'd be week 5 on the chart in the blue line. And the lockdown was officially announced in late March. That would be week 12, shown as a vertical line. So about a week or so before or leading up to the official lockdown, the government had been advising people to travel less, to work from home, to speak to, to see each other less often. And it looks like there's sort of 3 key bits of information in this chart. The first is when the reductions in ED attendances started, and they look like they started about a week before the official lockdown. The second key bit of information is the scale of the reduction. So it looks like ED attendances roughly halved immediately following the lockdown, from about 600,000 attendances a week down to about 300,000 attendances a week. And the third piece of information is the rate of recovery, the extent to which the blue line creeps back up to its usual level over the weeks following the lockdown. And rates of recovery started at about 3% of the baseline per week and slowed to about 2% of the baseline activity per week from about week 25 onwards. So they're the sort of key bits of information we can see from the chart. And there's 2 reasons really why we should be interested in this. The first is that, well, the NHS advises people to attend these major A&Es when they have an urgent and genuinely life-threatening condition. So what's the nature of the level and harm that has occurred as a result of the avoided activity? And more importantly, what can we do still about that? And then the second is that what can the reductions tell us about the scale of clinically inappropriate attendances? Might there be some insight in this data that could help us unlock some of the long-standing issues that are facing EDs? So COVID has had an enormous and really terrible effect on people's lives. And that change that's taken place gives us a sort of unique perspective on how health systems operate and behave. It won't come along again. We couldn't have engineered these changes, either through experiment or policy. It would have rightly been considered unethical. But it's happened, and we need to make sure we make the most of it in terms of learning what we can for the way we operate health services in the future. Unfortunately for us, the Health Foundation have produced a really useful framework to help us understand changes in healthcare activity during COVID. And the framework suggests that changes to healthcare activity can be attributed to one of the following factors. They're either because there have been genuine changes in population morbidity, changes in the rates of mental ill health, changes in the rates of communicable diseases like flu and RSV, for example, or changes in things like accidents resulting from workplace incidents, from outdoor play, from sporting events, or from road traffic accidents. So all those factors might genuinely change the level of illness or injury within the population that might result or require an ED attendance. And then there's changes in patient behaviour. When patients engage with the healthcare system, they sort of try and balance the risks of delaying their care or delaying an attendance or not attending at all against the inconvenience of attendance, the possible pain they might experience, etc. And COVID has changed the balance of risks by introducing a new risk, either of contracting COVID or of transmitting COVID inadvertently. And then the third factor is about policy choices, supply side factors. So on the elective side, we took a decision in the NHS to cancel a substantial proportion of elective activity immediately after the lockdown. We didn't really do that for ED. Most EDs stayed open and operated pretty much as they were before. But some of the agencies that refer into ED, their behaviour may well have changed. Ambulances, 111, GPs, they may all have changed their behaviour in terms of referral into ED. And one of the ways we can look at the sort of relative contribution of these factors is to look at subsets of the ED attendances. So to look at activity levels by gender or age or ethnicity, or by clinical condition or acuity, and that might shed some light on what really is going on with these figures. And I think we're making some real progress on that. We published a couple of articles with the Nuffield Trust and with the Health Foundation on why we've seen substantial increases, or decreases, I should say, in attendances for children. They've fallen off much more radically than we've seen in adults. But there's still a lot of really important and outstanding questions. So Alison, if you can move on to the next slide for me. So before I saw these figures, my expectation was that the vast majority of the avoided ED attendances would have been of the lower acuity or lower urgency type. That the most urgent attendances, well, there's not much people can do about those. They would have to go to ED if they needed resuscitation, or if they were if they're at death's door. But these figures suggest that reductions of about the same level, roughly 50% or thereabouts, we're seeing equally in all types of attendance, all levels of acuity. The most immediate and urgent, the least that's moderately urgent, and the more standard or non-urgent levels of ED attendance. And I'm not sure we have a credible explanation for the lack of gradient we see across acuity. It could, of course, tell us that the recording of acuity in EDs is very, very poor, but I would have expected a really substantial effect, and I'm not sure I'd have thought coding differences or coding issues would have obscured that effect in the data. So the fact might be that you can only really understand these changes if we look at a much more granular level of what's happening with ED attendances by illness and injury and condition, etc. But I think that's a job yet to be done to really explain why we're not seeing that, at least at face value, that gradient across acuity. And Alison, if you can move on to my last slide. So This slide shows that we saw much bigger decreases in ED attendances by Asian and black people than we did amongst the white population. So about 60% in Asian, 70% in the Asian population, 60% or thereabouts in the black or black British population, against a reduction of about 46% in the white population. Now that might be driven by differences in epidemiology. The Asian and black population in the UK is comparatively younger on average than the white population. But I think at least in part it's been driven by differential changes in patient behaviour. And to give you some context, so early on in the COVID outbreak, there were reports that black and minority ethnic groups were at greater risk of COVID than their white counterparts. And several big studies have subsequently confirmed this to be true, greater risk of hospitalisation or death. There were reports early on in the pandemic that people of East Asian heritage were being attacked in the street because of inexplicable concerns about whether they might be transmitting the virus. We had the Black Lives Matter protests that were shaping consciousness at the time. And on top of that, there's long-standing concerns about whether the NHS is meeting the needs of black and minority ethnic groups appropriately. So I think it's reasonable, at least to me, that at least some of that would explain some of the reductions, some of the excess reductions we saw in ED attendances amongst black and minority ethnic groups. So the question really is, what are the specific consequences for these groups of delayed presentation? How can we preempt or seek out these effects? And what can we do to ameliorate them? And there's a more general question for me about how we can help people assess the balance of risks between becoming infected or transmitting the virus if they attend ED against the risks of delayed treatment. I think there's a view amongst the clinical community that people aren't estimating those risks accurately and that they're delaying treatment when they should be presenting. So what is it we can do to help people understand the relative risks and make appropriate decisions in that context? That's all from me. Back over to you, Peter, I think.
Stephen, that was a great presentation. Thank you. Alison and David, have you managed to pick out a couple of questions from the chat that we can put about the presentation so far?
Hello, yeah, sorry, I might have a bit of background noise because I'm just in a public space because my connection at home is terrible. But yeah, we had a couple of comments on Charles's presentation about the years of life lost being an important measure, and when we might get more information on that. And then perhaps if I run through all the questions, then I can go back on mute, not being too disruptive. And then there was quite a lot of interest in the end of life information from Sarah, and just comments really about some of the difficulties around and some of the challenges with the data and the fact that we're missing some of the aspects around and nuances around the experience and choice aspects. And a few people have shared some interesting links here from National Audit Office work on end-of-life care, and the work from Ben Goldacre's team on overprescribing for palliative drugs. So I think that just the recognition of the challenges of measuring useful and meaningful data. And I think we've also got a link there from Elizabeth to the analysis that Stephen mentioned about the in children from the Nuffield Trust. And I think that's everything there. So I'll just go back on mute.
That sounds like Alison's public space is a laundry or something. Quite noisy. Just on that, so to Charles, just thinking just about the excess death, that you're kind of the work you've been doing on trying to help people understand the distinction between directly attributable deaths and excess deaths and so on. I mean, understanding that for the kind of historical record is really important. But why do you think it's important we understand that in terms of things we might then subsequently do? What might be the kind of insight that comes from that work?
So Peter, sorry, so you're talking about the impact of sort of excess deaths, why it's important to understand that, or more?
Yes. So the sort of unpacking of the whole sort of debate around how many deaths have been caused by this. What does that lead to?
Well, I think clearly there's one which is if you're trying to look at different countries' experiences of COVID, you obviously want to understand what impact it's had, and then you also want to try and understand why different countries might have got different impacts. So I think if you want to learn from it, and there are probably hypotheses coming out already about some of the things, about the effectiveness of testing systems, about the information that decision makers had and how they used it, about the timing of lockdown, and you know, about local lockdowns. I think in order to kind of learn and compare, you need that. And I suppose the other thing is that you want this data because it kind of, like, I think there are one of the things that clearly the government and everyone has been struggling with is about the balance between, and I'm not sure there is a clear distinction between these things, about measures to safeguard the economy versus measures to safeguard health. And clearly there isn't a complete trade-off. Like, actually in the UK, we've had a harder hit on the economy and on health than other countries. So, but there are, you know, at the moment, the whole debate around opening things, and I think, you know, we need those measures of impact to actually be able to retrospectively look and think, you know, what was the right, did we get the balance right here? And that's not to say we made the wrong decisions, because actually at the time we probably didn't have all the information we needed. But in order to learn about that, that seems to me an incredibly important part of the kind of analysis of what we did.
Great. And Stephen, you just sent me a note to say you've got something to say about the years of lives lost question.
Just to train a piece of work that's coming out shortly, a colleague of mine, Paul Seam, has been working on that particular question, how we can estimate years of life lost over the COVID pandemic. And the British, I think they're called the Association of British Actuaries or something like that, have been doing quite a lot of work on this topic. And Paul's been trying to sort of summarise and glean the relevant information out of that for people to understand and try and translate it to useful metrics for us. And in particular, to try and put the excess deaths we've seen from COVID into some sort of useful historical context, so that we can see its likely impacts on metrics like mortality rates and life expectancy, for example, over the next few years.
Great. And
in a couple of weeks' time.
Great, thank you. And then a lot of questions in there about what can we do more to understand the experience of dying that kind of underlay what you were describing, Sarah. I mean, there's been such a so much of a sort of sense collectively that supporting people to die at home is a better way to proceed. It's what more people say they want in anticipation of it. We've now done it at scale, but we've probably done it you know, force majeure in some instances. What's your sense about whether there's more that we can do, or whether there is something being done to try to really unpick that experience and what we can learn from it?
Well, I think in terms of the experience of patients and families, then I'm not aware of anything that's going on to understand that directly. I think there's more that we could do potentially with understanding what services provide in the community, although the quality, although some areas have got good local community data, the national picture isn't very good. We've started some analysis using community data, and we reckon really we can only use it for about a third of the country because of data quality issues. But I think there's a lot more that could be done looking at, in primary care and community services, what support's being provided for people, but that won't really address the experience of patients and families that I think probably needs a more qualitative approach to understand that better. So I'd be really interested to know if anyone's aware of work going on that.
Yeah. So if anyone is, if anyone's aware of anything on that, please post it.
Yeah.
And we can share. Okay, well, we're gonna move on a bit in the discussion now, but please keep posting your questions, and we'll come back at just the last 10 minutes or so to pick some more of those up. But for this bit of the discussion, we're really trying to think about given what's happened so far, given the work that's been done so far, what people think are the most significant gaps in understanding, the biggest uncertainties which we need to be able to unpack if we're going to do the best job we can of navigating going forward. So perhaps Charles, just to start with you on that, you know, from your sense of the work you've done so far, what would you say are the kind of the most important, almost like the known unknowns? We know there's we have got good reason to think there's an issue, but we don't understand enough about it at the moment, and we really need to.
Yeah, thanks, Peter. So I think we are, I mean, probably like quite a lot of people, after this, you know, the kind of first phase of the pandemic, we're trying to stand back a bit and think, okay, so what, you know, there was like a massive amount of analysis generated by lots of different people. Everyone became experts quite quickly. Now standing back is absolutely the right thing, Peter, which is like, well, what don't we know? Like, because obviously there's lots of people doing the same kind of stuff, but in different ways. But there is probably some really big areas we just don't, no one's been working on, because it's been quite hard. It's, you know, the data we've had doesn't enable analysis, and people haven't gone there. You know, I personally think we've, you know, had this big focus, and probably the health system has been focused on preventing deaths. But, and, you know, lots of the data we've got is about deaths. But the question about what are the kind of broader health impacts. So I'm in particular thinking about the point I was making earlier about, we understand a lot about how people aren't getting the treatment they were getting, the levels of treatment, but we know very, very little about what impacts that has got. And again, I think it comes back to, you know, the slogan about protecting the NHS. You know, we basically went into the pandemic probably with, well, we know this internationally, with relatively low capacity in terms of beds and doctors and nurses. Partly the way we dealt with that was where we built new hospitals. That was incredibly impressive. But we may well have basically, you know, emptied hospital beds to free up capacity. You know, if we'd had more, we may not have had to do so much of that. You know, we know that we actually discharged a lot of people into care homes. Sarah's point about, you know, people are maybe not going into hospital to near the end of their life, and that might actually in some cases save people, or they're being discharged with, you know, kind of earlier. I think that those kind of questions about what's the impact of that are really, really important. And I think, you know, the question about NHS capacity and what capacity we might need, not just to deal with another COVID, but to deal with other kind of disruptive things. You know, it feels to me like we do really need to understand the impacts of the way that we run the NHS and how we deal with these things on people's health.
Stephen, any particular perspectives on that from your point of view? What's the thing that you've got a burning desire to try and answer next?
Well, I broadly concur with Charles. I think just thinking back to Charles's 2x2 grid, I think attention has been focused on the top and the right sides, and our attention should shift more into the bottom left-hand box, which, if people can remember, was the bit where it's the impacts of people who didn't get COVID but who are still alive. Yeah. I think that's where the greatest opportunity is to make a difference, and I think it's where less attention has been paid to date. So that's where I'd encourage people to start looking. And it's not an easy thing to do by any means. Trying to find out what the consequences have been of an event that didn't happen is really tricky to spot. But I think that's the challenge for analysts going over the next 2 or 3 months. That's what I'd encourage people to start looking for. I think there's a lot to be gained by looking into that area in more detail.
Say a bit more about the analytical challenge in that, Stephen, because you've got some people on the call who are deeply analytical, and some who probably would really welcome your insights about why that's a challenging question.
There's a couple of things really. One is the sort of ubiquity of the COVID effect. So normally as analysts we're playing off differences over time, differences over areas or between people, but COVID did seem to affected everybody, not just in this country, but it affected almost every country. So trying to find suitable comparisons to try and observe the effects of COVID is tricky. But the other challenge is just this fact that if we were trying to observe the impact of something that had happened to people, for example, trying to work out what the impact is on people who've got COVID in terms of their long-term health, we can start by knowing who they are. We start by knowing there's a group of people and we can track through what their healthcare use is, what their morbidity over a period of time is. But in this case, we're talking about trying to track through the effects of events that didn't happen. So we don't know who they didn't happen to. And so tracking those effects on an individual level is just fundamentally more difficult. There are ways to do it, very clever sort of study designs that will help us get to that fact, but it's just fundamentally a more difficult task.
Yeah. Sarah, any from your perspective on that?
I mean, a couple of points really. I mean, I think you know, longitudinal analysis. So I think some of these are problems that we need to think of as being our work programme for several years ahead, not just, you know, not things we're going to answer in the short term. So longitudinal studies of the impact of patients, particularly in the community. So at the moment, we know who is in hospital with COVID, and we can follow them up after they've been discharged through linked data sets, or we will be able to do that. The unknown issue, I think, is identifying people who may not even have realised they had COVID, or who thought they had it quite mildly, who didn't seek help at the time. So I think getting a handle on that cohort of people and being able to track them over time and understand the impact, I think that's going to be really important. I mean, I think in the shorter term, probably, I think we could potentially look at issues now around the prioritisation of services. So particularly if you think around cancer services, heart disease services, heart failure, some of those things where we could do more for people right now. I think there's important analytical questions there. I mean, as Steve says, challenging to address, but nonetheless, there should be data there in primary care in particular to identify at a population level some of those groups of patients. And I think, again, just to reiterate the point about what's going on in terms of community services, is just a bit of a black hole, really. So that's something where hopefully the need to know that might spur on some more consistent data collection in that area.
I mean, we've seen, well, we're at the beginning of a second wave, or are we? But clearly things are there has been some raise in activity and infection. Is there something we should do in terms of data collection during this next period that could help us get a better grasp on some of these questions? Is there an opportunity to gather some new data that would address some of the analytical challenges you're talking about?
Well, I think in primary care, I think understanding how COVID-related illnesses have been captured, I think that would be quite critical. I know that NHS Digital is doing some work around GP appointments data, but I'm not sure if it's as wide as that. And they've recently also started publishing some GPES data, or not publishing it, but making it available via DARS. So I think work using some of those data sets could be really valuable. I think a lot of the community surveys that have been going on, so the work that ONS have been doing and other organisations, I think it would be good to sort of think about where there are gaps. So there's a lot of that. A lot of those really valuable surveys are happening, but sometimes it's quite hard to know what they all are and to understand if there are gaps and topics that aren't perhaps well covered. between Understanding Society and ONS and, you know, some of the other surveys. So I think that was an important and interesting piece of work as well.
Yeah. Do we think, is it likely that the sort of research community will naturally settle on these questions, or is there an opportunity, is there a need, do you think, to try to kind of hone these down and create a bit more of an ask to the research community about some questions?
Yeah, I mean, I think NIHR have a funding call at the moment of COVID-related work with quite a long list of questions. I'm not sure in terms of what they've funded and whether that's published yet. They do publish what they fund, but I don't think that's out yet. But I think that's an important point, actually. I don't know if anyone else wants to come in on that.
Yeah.
And the other area, noticing some of the points on the chat, I think is around carers and impact on carers, I think is another massive potential area, thinking about long COVID as well.
Charles, any thoughts on that? You're on mute, Charles. Sorry.
Thanks.
Sorry.
I mean, I think I'm just going to go back to thinking about because I was thinking as Sarah was talking about some of the, you know, what additional data might we want. You know, I think that question about what are the impacts of people not getting healthcare, it's really difficult to answer because we don't actually collect as much information generally on this as we'd like. You know, so we've got patient recorded outcome measures for some things. We generally don't really know enough about what health services contribute to health, I would say, which makes it quite difficult to answer that question. And I think, you know, and actually, I think Stephen knows this because we've been talking about this as part of our launch report. You know, we don't actually know enough about that to be able to say, you know, what should be a better allocation of healthcare resources between primary care, secondary care, etc., because we don't know enough about the contribution it makes. So I think, you know, it's not just about data around COVID, it's more generally.
Stephen, any thoughts from you?
Yeah, it's just generally one of my sort of long-standing frustrations that we distribute 120 billion pounds of the country's wealth every year to health services and associated services, but there doesn't seem to be any really clear steer on the relative distribution of those resources by condition, or by sector or point of delivery, and I think there needs to be there's more role for analysts and policy leads to take in trying to guide changes in distributions of resources. Really subtle changes, for example, towards primary care and away from secondary care, might make a really substantial impact on the population's health. And we've been calling for those sorts of changes for many years, but actually what's happened over the last 10 or 20 years is that we've gone in the opposite direction. The share of resource use by the primary and community sectors has decreased relative to the acute sector. And we don't seem to have a really clear way of steering allocation decisions, maybe towards things like dementia, or away from cancer, for example. There's no mechanisms that I can see that really would bring that about at the moment. So yeah, I think more attention on those sorts of issues. It's a bit off the topic, but I think that's definitely an issue that we should try and address over the next sort of 10 years of the health service.
And it's not entirely off the topic, is it? Because well, it's not at all actually, because there are a lot of people are trying to take this opportunity to have fairly fundamental rethinks about balance of service and the design and organisation of service. So, you know, this sort of reset rather than recovery. But also it did strike me. I don't know. I mean, I'll say this, and then you can all tell me whether you think this is an unreasonable observation. But you know, as a country, we have huge sort of refrigerated warehouses full of things to prepare us for pandemics. It transpires now whether they were full of the right things or not is but you know, we do have these huge preparatory arrangements, and a pandemic's been very high on the nation's risk registers for decades. And yet, as we hit this one and we confronted the question of how do we free up capacity for one thing by reducing activity for other things, we didn't seem to have in our refrigerated warehouses a pre-thought through assessment of what would you stop, what can you stop with limited effect, and what you really should you not stop at all if you possibly can. That doesn't seem to have been worked out. And we had all sorts of activities once it got going, with various Royal Colleges coming out with ideas about how you might prioritise surgery, but we just don't seem to have a settled sense as a health system about the kind of rank order of impact of what we do. And so it just seems to me that kind of thing you're talking about is part of that same question. Which is that mad, Charles? Was that mad? Should I be shot for saying that?
No, I don't think so, but others might.
Yeah.
And I think, though, it's a difficult question to answer even now, in that, I mean, if you take Steve's A&E analysis, it does seem surprising that A&E attendances have dropped off across all severities, but it's very hard to know what the implication of that is, and is that treatment deferred, where some of those people, did come but aren't attending as often, or were treated in the community by paramedics. It's there's just so much that we don't really know, I think. But I agree that in our answering that will help us with what we might stop next time.
I wonder if there's, I mean, the other thing I'm thinking as we're having this conversation is, linking back to where we, should be investing as we kind of recover or build back. I wonder what people think about, there being a risk that the acute sector will just suck more in, because it's had such huge prominence over this period. Already the discussion is, and I'm not saying it's wrong, but on recovering of elective care lists, much less about perhaps on, people with long-term conditions and exacerbation of those, or, and they've actually been probably not enough on the spotlight recently. And so it feels that, better analysis of or information about this could actually help the build back. It feels to me that we probably need to be, as a community, trying to shape how the NHS builds back, and ensuring that it doesn't become even more acute sector skewed. There is an opportunity here, but it's an opportunity for it to go wrong as well.
Yes, absolutely. I mean, some of the feedback, some of the discussion in the session on social care actually strayed into how much more problematic the experience of how we adjusted services seems to have been for people who are in contact with mental health services, or who are reliant on social care services. In terms of feedback in one of the qualitative reviews we've been doing in part of our patch recently, it seems that confidence levels on the public side about the way mental health services have been able to react to this are lower than they are about other aspects. And then the work that's been done recently by Andy Hood and colleagues, trying to forecast what the likely bow wave of mental health impact might be from the initial period. All those stacked together to seem to say maybe that ought to be much higher up on the list of focus for what we're going to do about recovery. But anyway, any other questions that you think? I mean, so this whole thing about the consequence of lost opportunity to engage with health services, and what what that means is clearly a very significant one. But what other questions do you think are there where we need to do more to answer them? Sarah.
It's quite an interesting point coming through on the chat about workforce, which I think is really important. So if we're changing, or for all of these things that are happening, what we're delivering is very different to what it was a year ago. So in terms of the amount of care that's being delivered remotely, whether that's on the phone or through other means, and some of the shifts that we've seen in activity. So what's the implications of that for our workforce? I think that's a hugely important area, especially since that we went into the pandemic with so many workforce challenges across social care in particular, as well as health. So I think that's another area for understanding better what the implications are.
Charles, another one from you, and then Stephen, and then I'll just have a quick look at the questions that have come through. I'm
going to pass to Stephen for the moment because I'm still thinking.
You can't think on these things, Charles. Stephen.
Yeah, so just again picking up on Andy's point in the chat. I mean, the issue is not just about how many new staff of each additional type we choose to train and employ, but it's about how we deploy those appropriately. I don't know an answer to Andy's question, but just a point to illustrate the importance of it, really. Which is not mine, it's Muir Gray's, one of Muir Gray's stories, which he points out that the big increase we saw in GPs a few years ago were intentional. We deliberately went out to try and increase the number of GPs. But retrospectively, looking back, it appears that most of the additional time that those GPs contributed to the system was spent ordering and assessing tests. And I don't think that's really what we wanted those people to be doing, but it happened naturally. Unless you take a stronger steer on some of these issues, then just employing the staff and increasing resources, they won't necessarily get deployed as you want them to. So Andy's quite right, we need to link up sort of the workforce plans with our service priorities to make sure we get best use of the new resources that we spend.
Yeah. And maybe there's, I mean, so that's one of the things that our new centre is going to be doing a lot more work on, the kind of workforce. And I think there's probably also something, isn't there, about, again, linking to our needs. This has highlighted the need to have a health care system that can adapt and be flexible, because we never really know what's around the corner. And that might, point you towards roles, training a workforce that can be more adaptable. So, the hyper specialisation, probably leads to us at NHS just doing more hyper specialised activity. Is that what we want? And is that, in a kind of pandemic or other kind of crisis, is that kind of what you necessarily want? I mean, the other thing I wonder about is, it strikes me that money for the NHS, public finances are in a terrible place anyway, but money is not going to be, there are constraints which bite more than money. So even if you threw billions of extra pounds at the NHS, it probably could not absorb it. And that's partly because the workforce, we can't train a workforce quick enough. So if we were going to have a health service which could respond over the next few years to the kind of new pressures that are coming up, would that mean different kinds of roles? So, I mean, stuff like, people who are the social prescribing kind of things, like they are presumably, some of those staff could be trained up more. Some of the mental health, I'm not, clearly there are very, very important specialist activities in mental health, but there are also lower level things like, the way that we trained up people to do cognitive behavioural therapy, that was much quicker. So I'm also thinking, does that point us to kind of different kinds of workforce, particularly to address short-term pressures?
Yeah. And then this whole topic of how we understand societal choices still seems really,
yeah.
The because you know, a lot of what we've talked about, you know, that there are ways to look at it from a technical perspective, but so much of it boils down to value judgments and in effect political choices. You know, do we spend more attention on mental health or on children or on frailty? They're not amenable to a single technical answer. And how we work with citizens to try and form a collective informed view on how to make those choices, just that again seems to be now is a time perhaps to try to start thinking again hard about how we do that. Look, it's been a really great discussion. We're nearly at 25 past. I just want to make sure that if there's any other particular questions, so, Alison, I don't know whether you're still in.
Peter, I've been monitoring the chat.
Great. Okay, David. And any apart from, I've resisted asking the panel the question of, have we overreacted to all of this? Which I was keen to ask you, but I thought you might not want to answer it and be recorded about that. So any other questions, David, that
there was one that I don't think has been covered in the discussion from Sharon, that was, as different areas go onto government watch lists, including additional restrictions, it would be good to be able to assess impacts at a regional level, especially on mental well-being. And then there's also another one related to the workforce stuff you've just been discussing from Andy about how much switching of activity is possible or useful with highly specialised services and staff. So I think that's been covered a bit in the last few, but those are the main questions that have come out in the last few minutes.
So so an interesting one there from an analytical point of view is there do we need to take advantage of, almost from a point of view of learning, of the fact that there are regional and local differences, and is there something we need to do, I don't know, almost structurally from an analytical point of view to agree we're going to capture that?
That's right.
Yeah,
I think it's a really good question. Actually, that was one of the things I was going to mention earlier as well about, you know, I talked about learning between countries. I think there's a huge amount of learning we can do between regions and different areas of the country. In all, you know, there's so many differences, and we should be learning from those, because actually we have got, you know, the capability of getting data. You know, we do have local data.
And I think there's also differences across the United Kingdom, across the 4 countries as well. Might be another interesting area to learn from.
Yeah, I was talking to a chief executive of one of the big hospitals in our region the other day, who told me that in their particular hospital they only stopped elective care for 24 hours through the entire period of COVID, because they chose to take a different response to it. Now, you know, I'm sure there'll be more nuance to that when looked at it, but there's got to be some advantage in trying to look at what the experience in that area compared to others, to see what the consequence was of that decision. Anyway, look, what I would like to do first of all is to thank everybody who's joined us for giving your time, and then secondly to thank the panel for some really stimulating, fantastic presentations and for your insights in the conversation. I want to also just remind people that this is the end of week 1. Gosh, only week 1, only 5 to go of the Insight Festival, and to encourage you to thank you, Alison. Yes, I can do this properly now. So coming up next week, and look, we realise everybody's incredibly busy, so we're not assuming that people can attend all of these things, but we would love it if you can attend some, and they will all be recorded as a resource thereafter. But next week is concentrating quite heavily on the arrangements that are in the Midlands to create a network of what we're calling decision support units, but focal points for analysis, evidence, evaluation and learning in each of our ICSs or STPs, and creating a network of those. So next week is spending a lot of time talking about those arrangements. So lots in there that's particularly relevant to people from the Midlands region, but maybe also, well, actually definitely also for people elsewhere who are thinking about how they might try to organise and network this type of activity in order to get scale benefit. And it does seem to us that one definite lesson of COVID in terms of analysis is that is that we have to find better ways of connecting up and learning from each other when we're dealing with so many issues of uncertainty. Anyway, thanks again. If you could all put your cameras on. I think I learnt this off Karen the other day. So if everyone puts their cameras on for a second, and then you can show visibly your appreciation of the panel by doing a bit of clapping, and then we'll finish it off. So thanks very much, everybody. Thanks for your participation, and we'll see you all soon. Okay, thank you. Thanks, Charles, Sarah, and Stephen. Thanks very much. Bye.
Thank you. Bye.
Right. Thanks.